Pulp talks in its development and throughout its lifespan in the most turbulent environment of the oral cavity. Pulp talks when it's threatened or injured. Pulp talks outside the oral cavity in research and in new scientific discoveries of its potential to survive. And to discuss with you about many aspects of this pulp talk, we have three elite professors well known throughout the world. I will not be boring you with a full description of their CVs. So I'll just give a brief introduction because to our audience, they are no strangers. Professor A.K. Sarambavatta, Senior Professor in Dental Anatomy, Head Department of Basic Sciences. And he has taught many of us dental anatomy and need no further introduction to our audience. So he would be talking about the development of the tooth and the pulp, including how pulp responds to injury. And then he'll be followed by Professor Manil Fonseca, Professor in Restorative Dentistry. He's the head of the Department of Restorative Dentistry. He's a renowned clinician and a teacher in clinical dentistry who will enlighten us today on how to manage the pulp in clinical setting and the protocols and guidelines in the management. Professor Varna Disanayaka, who is a proud product of the Faculty of Dental Sciences, University of Peradeniya, is the Assistant Dean, Electives and Experimental Learning, and Assistant Professor in Oral Biosciences at the University of Hong Kong, who's joining us from Hong Kong today. His areas of research expertise lies in tissue engineering to derived stem cells and pulp regeneration. He has many publications under his name and has contributed to quite a few book chapters in biodegradable materials, their applications, biomaterials in endodontics, dental stem cells, regenerative potential. So just to name a few, just to give a brief sort of introduction of him, because he's a little new to our audience in Sri Lanka. He will be discussing with us today about the new developments in the field of pulp regeneration and the future directions of the pulp talk. So with that brief introduction, I would like to invite our presenters to start their presentations. So Professor Arambavath will start with his presentation. Over to you.
This invading microbes or the toxin to enter the pulp through these barriers. So this is also very important mechanism. And the final outcome of the these barriers, of course, formation of tertiary dentin reaction or reparative dentin, it decreases dentinal permeability by sealing of these dentinal tubules plus formation of intratubular peritubular dentin formation, and therefore it isolates pulp from microbial toxin. So therefore it enhances potential for pulp survival and healing. So these are the barriers which is mainly responsible action by the odontoblast. So what even for these barriers, with having these barriers, some of the microbes or the pathogens or the toxin can even manage to enter the pulp. So what are the immune response once they enter the pulp? So there are two types of cells. One is specialized non-immune cells, as I mentioned earlier, odontoblast and stem cells. In addition to that, there are immune cells which are located within the matrix of the pulp. They are known as macrophages or dendritic cells and other T lymphocyte and other kind of inflammatory cells. So how odontoblast act as immunocompetent cells? Because they express some recognition receptor. They have some recognition receptors called toll-like receptors, and they can detect some of the bacterial component and Therefore, they initiate certain kind of immune reaction. So these cells act as first immunological barrier at the pulp-dentin interface. And what are the other cells? They are mainly resident immune cells, mainly macrophage. They are the most prevalent and performing constant immunosurveillance in the pulp region. In addition to that, during the infection, there are other type of cells recruitment, neutrophil and monocyte and T lymphocytes as well. So when you talk about this molecular insight and signaling activity of the pulp in the inflammation of the pulp against the invading microorganism, these cytokines and chemokines play a big role, but they produce in inflamed pulp and contribute, some of these contribute pain and tissue damage also. So this is balance between pro-inflammatory and anti-inflammatory mediators. So this is very crucial for determine whether the pulp proceed toward necrosis or regeneration. It is all these molecules or cytokines or chemokines play a big role. Finally, whether pulp is going to be a necrosis or regeneration, there should be a balance between these two factors. So result is hyperalgesia and spontaneous pain. In addition to that, these fibers also release neuropeptides also, and it is cause vasodilation, plasma extravasation, and mast cell activation. This is very important again, the vasodilatation and the plasma extravasation. This is sometimes cause harm, or sometimes it is damage to the pulp, or sometimes it is advantage of a fight against the invaded microorganisms. So all these factors will amplify the local inflammatory response with the other kind of factors. So finally, the outcome of the pulpal inflammation, it is, as I mentioned, is balance between vascular inflammatory expansion and neural sensitization. Then it determines whether the symptom severity and the likelihood of reversible or irreversible pulpitis. So this is the main factors which determine whether we can save the pulp from this inflammatory reaction, or whether it's going to damage and end up with the death of the pulp. So excessive vascular pressure, you have to be very because it is a soft tissue covered by, encircled by hard tissue. So you need to regulate the vascular pressure. Therefore, the impaired circulation predisposed to pulp necrosis, while controlled neurovascular response support healing. So this is the balance between these two. So other than this, the outcome determinants, for example, it depends on the intensity and duration of the microbial challenge, whether it's going to be a slow, or whether it's a intense one, whether it's going to be a acute or chronic one, and some of the host factors, vascular status, as in young people, young pulp, this is a very rich blood supply, and immune competencies and age-related changes in the pulp also can contribute for the outcome of this the pulp, whether it's irreversible or reversible pulpitis. In addition to that, the factors which cause pro-inflammatory and reparative pathway determine the pulpal survival. Some of the factors which increase inflammatory activity, some of they are balance in the inflammation activity, so they are balance determine finally survival of the pulp. So this is what I was thought of talking about the under my topic, to the pulp development, the structure, and how the pulp react against the invading microorganisms, and what are the factors that we have to think of when we dealing with repair and regeneration of the pulp. So I think as I will finish my part by giving this, the best dentist is not what we remove, but what we help to regenerate. So we have to keep calm and let the pulp heal itself. But if the inflammation or the irreversible damage happen to the pulp, what we are going to do? So I will invite Professor Manil Fonseca to, talk about what you are going to do when the pulp is irreversible. All the defense mechanism fail and the pulp get damaged. What are you going to do?
Thank you very much, Professor Arambavatta, for highlighting a lot of aspects with regards to the pulpal complex and how the regenerative as well as the repair as well as the defense mechanisms act. I think let me share my presentation now. Right. Hope it is visible.
It is.
Yes. So my task is basically to talk about the current strategies in vital pulp therapy and to direct you from the traditional treatment protocols of trying to do root canal treatment for each and every tooth which is suffering from pulpitis to a more conservative and a biologically sensitive way of managing. We were quite engrossed in the fact that the traditional therapy, which involved extirpation of the pulpal tissue, disinfection of the pulp space, and sealing of the root canal space with gutta percha and sealant, effectively known as root canal treatment, was basically the to-do thing in situations where pulps are either irreversibly inflamed, non-vital, or any other sequelae of pulpitis. So there was very limited understanding about the behavior of the pulpal cells, the pulpal tissue. A lot of arguments came highlighting the fact that it is an end artery that supplies the pulp, and therefore once inflammation sets in and hydrostatic pressure increases within the pulp chamber, it's basically the end of the road. So invariably, you will find that the pulp necroses, and therefore we instigated treatment in order to remove the inflamed or necrotic pulp and restore it with root canal filling material, gutta percha, plus the root canal sealant. But as Professor Arambavatta highlighted, there's a lot of evidence to suggest that the pulp, in fact, has an ability, an innate ability to heal, re-secrete tertiary dentin, as well as manage the inflammatory process on its own, because it's a highly cellular and a vascular tissue. This argument of end arteries, if you look at a multitude of organs in the body, and the tooth is also considered an organ, your kidney is supplied by an end artery, the spleen is supplied by an end artery, and importantly, even your even your heart, the vessels are end arteries. And nowhere in medicine do we find that in situations where there's inflammation in these tissues, we simply remove the tissue and put an artificial material inside. So we are going against biology in a lot of situations. This I just put to break the ice. Most of the time, our diagnosis of pulpitis is based purely on the clinical interpretation. So the patient will give you signs and symptoms. You will elicit certain signs. You will depend on radiography to identify any changes in the periapical region and then determine the diagnosis. But what the clinical features don't tell you is to what extent this inflammatory process has gone through. So even if a tooth is irreversibly inflamed, this may only affect the superficial layer of the pulp, whereas the underlying pulp might be healthy and might be able to wall off the infection, wall off the inflammation, react in such a way that healing can take place, and most importantly, keep the tooth in a vital state. Studies on traumatized teeth has shown very promising results for simple procedures such as pulp capping, pulpotomies, partial pulpotomies, and complete pulpotomies. And there, the fundamental difference was that the traumatic exposure was a very sudden, acute exposure where there is not enough time for a lot of inflammatory processes as well as infection to track in, right? And learning from this experience of trauma, now the European Society of Endodontists as well as the American Endodontic Society have developed what is known as a position statement and highlighting what needs to be done with regards to caries exposures as well. If you look at literature, reversible pulpitis shows over 95% survival of the pulp over 5 years when you use bioactives as pulp capping agents, or in certain situations, if you go for pulpotomies, again, it gives you a 95% survival of the pulp over 5 years, right? Irreversible pulpitis still is a bit controversial because if you can determine the extent of the inflammatory process within the pulp chamber, you may be able to be more conservative in your management. However, some studies have shown that irreversible pulpitis with no apical pathology shows about 92% radicular pulp survival over 5 years. And these are critical information you have to bear in mind when you're dealing with the pulp being angry. Now, there are certain advantages of vital pulp therapy. Maintaining vitality of a tooth is a very paramount feature and an objective you should try to achieve, right? Why I say that? If you preserve the vitality of the pulp is able to continuously respond to stimuli and injury. Whereas if you extirpate the pulp and do root canal therapy, the problem at that point is sorted, but subsequent insults, there is no tissue to respond. So therefore, there's a lot of justification in trying to preserve the inflamed pulp, preserve a vital pulp. A lot of you might be experienced with the fact that once you do root canal therapy, eventually, or with the medium to long-term scenario, the teeth fracture off because of the brittleness, lack of moisture, and the lack of the pulpal coordination to reinforce the tooth. So the complications following RCT is minimal. And of course, you're trying to be biologically more conservative by preserving a vital tissue. Now, before we move on to treatment strategies, I just want to briefly highlight the classification of dentinal caries. We now classify based on the depth of penetration, shallow, medium, deep, very deep. And of course, you get into a situation where you have pulp exposure. And of course, we talk about D1, D2, or D3 lesions. So D1 and D2 lesions, we are not going to talk about here because there's no effect on the pulp or very minimal effects, and simple restorations would work there. But D3 lesions, depending on the depth and depending on the nature of the residual dentine, our treatment strategies might vary. Dentine, again, dentine affected by caries is also subclassified into soft dentine, firm dentine, as well as hard dentine. The hard dentine is sound dentine, which is not affected by any demineralization process or infective process. So it is very hard and it doesn't penetrate in probing and stretching. But firm dentine is dentine which is affected by the enzymatic degradation of the bacterial caries process. It is not really infected, but it is softened as a result of the enzymatic degradation of the collagen as well as the hard tissue. So it will be resistant to excavation, but if you apply sufficient force or use an appropriate excavating device, you should be able to excavate that. And soft dentine is dentine which is infected by the bacteria as well as liquefied, very minimal or no collagen, and it is easily excavated. You can just scoop it off without any pressure applied on the instrument. So in deep caries, Caries affecting the inner quarter of the dentine with a zone of firm or hard dentine between the lesion and the pulp. If you have that scenario, you're very safe. You manage it with the recommended materials, which I'll come to later on, and you can expect near 95 to 98% success long term. But if caries is extremely deep, caries has affected the entire thickness of dentine, and the pulp exposure in your determination is inevitable during excavation, then you have to be careful. A lot of literature suggests that if you do indirect pulp capping, the survival of the tooth and the survival of a healthy pulp is better than doing direct pulp capping. So in this situation, what we recommend is to excavate the periphery of the cavity into hard or firm dentine, but where caries is affecting on the pulpal surface, you can leave soft dentine, use your bioactive materials such as calcium hydroxide, MTA, biodentine, and we now have a newer additive called nano bioceramics, which they all show promising results in terms of pulpal healing as well as a dentine bridge forming. This I have extracted from the European Endodontic Society position statement of management of deep caries. So I welcome you to go through this document, and it will highlight the guidelines and the basis for their strategies. So going into the procedures, indirect pulp capping, you basically have to remove the peripheral softened and firm dentine. So your periphery of the cavity should be nice and infirm or hard dentine. And that is an important consideration. But the pulpal region, you can leave a layer of soft or firm dentine without excavating completely. Use this hydraulic calcium silicate cements or glass ionomers followed by restorative material as required according to the clinical presentation. And out of the hydraulic calcium silicate cements, we have a variety: calcium hydroxide, MTA, as well as biodentine, and also the recent introduction of nano bioceramics. Out of these, calcium hydroxide, although it is a very sought after material and has shown very good success, the fact remains that the dentine bridge form, when calcium hydroxide is applied, is very porous, and therefore there can be continuous microleakage. Whereas using MTA and biodentine shows a better and a stronger dentinal bridge between the carious lesion and the pulp, as well as the fact that MTA and biodentine helps healing the pulp due to its very inert and biocompatible nature. Direct pulp capping is advocated mostly in the current context for traumatic pulp exposures. If the pulp exposure is carious, the recommendation is to go for a partial pulpotomy or a SWEC pulpotomy, which has been described in the early 1970s by SWEC. And here, with a direct exposure of the pulp in direct pulp capping, you're recommended to use MTAs, biodentines, and the nano bioceramic sealers. One disadvantage of MTA is the fact that MTA tends to discolor teeth because it is grayish, and therefore the hue of the grayishness may be seen through your restoration. So either you have to go with white MTA, or in such situations, if you have available biodentine, that is the material of choice. Then if we move on to the next procedures, if there's carious exposure, the current guidelines or recommendations is that provided the patient doesn't have irreversible pulpitis at the onset of treatment, you go ahead, remove about 1 to 2 millimeters of the coronal pulp, apply sodium hypochlorite, and observe whether there is continuous oozing of blood or whether there is any evidence of exudation. If that has stopped, then you can come to a conclusion that you have removed the inflamed and affected pulp, leaving a healthy and vital pulp underneath. And therefore, once you do that, you can use again MTA Biodentine is not very well recommended in this situation because it tends to be affected by moisture, but you can put a nice barrier of MTA and restore the tooth. And if if your diagnosis is irreversible pulpitis, the objective here is to preserve the radicular dentine. So you can go for a complete pulpotomy and carry out treatment. Same principles apply. You extirpate the entire coronal pulp, observe to see whether the radicular pulp is healthy. How you do that is if there is pinkishness, where there is no oozing of blood into your pulp chamber, you're assured that the radicular pulp is not affected by the inflammatory process, and therefore you can preserve it. And of course, the final situation, when it is non-vital or if the patient has periapical periodontitis, then of course you go for the traditional root canal treatment. So materials, I thought I'll just go through a bit about dental materials here. So in deep caries lesions, what is recommended is resin hybridization or glass ionomer, MTA, biodentine. All of these can be used as indirect pulp capping agents. For pulp capping, the recommendation now is MTA, but if it's an aesthetic concern, you can go with biodentine or white MTA. Pulpotomies, the recommended material is MTA. And of course, the nanobioceramics is also coming up, but now we have to wait some time before it is comprehensively applied to clinical guidelines. This is an example of a partial pulpotomy done. Two critical factors to determine the success. One is very strict isolation using a rubber dam. If you have not used a rubber dam, then your success rate is significantly low. So if you're doing partial pulpotomies, it is critically recommended that you use a rubber dam for isolation, preventing any oral flora or minimizing the effect of oral flora on the exposed pulp. So partial pulpotomies show better outcomes for carious pulp exposures. You remove the biofilm if the patient is suffering from reversible pulpitis is fine. Currently, according to current literature, it is not indicated for irreversible pulpitis. And once you have removed a certain portion of the pulp and ensured that the remaining pulp is vital, you can use hydraulic calcium silicates. Calcium hydroxide is not recommended anymore. So basically, the recommendation is using MTA and nanobioceramics. This is a section I have taken from a publication. So what I've done is I've highlighted the important aspect which is of consideration here. So mature permanent teeth clinically diagnosed with irreversible pulpitis are treated with pulpectomy and root canal fillings because the inflamed vital pulp is not capable of healing. That is the traditional description. But however, if you look at histological studies, they've demonstrated that clinically diagnosed irreversible pulpitis does not involve the entire pulp. And therefore, if we are prudent and careful enough, we might be able to stop short of doing a complete pulpectomy and root canal therapy, because if you identify the demarcation between the irreversibly inflamed tissue and the vital tissue, you might be able to get a good success rate. And there's poor correlation between the symptoms and signs the patient presents with and the amount of effect, the thickness of the pulp, which is affected by the irreversible process. So in coronal pulpectomy, you preserve, the objective is preservation of the vital radicular vasculature. It is recommended for reversible pulpitis and partially reversible pulpitis confined to the coronal pulp. So you extirpate carefully under rubber dam and proper magnification, of course. Disinfect the pulpal surface with sodium hypochlorite or chlorhexidine, or sometimes they recommend ferrous sulfate. And then you use your MTA. And importantly, the periphery of this cavity should be clean and sealable with a hermetic restoration. So if you have softened dentine on the margins of your cavity, the success rate is very bad. So therefore, make sure that the periphery of the cavity is cleaned and the margins are in firm or hard denting. This is a treatment we carried out in a premolar with irreversible pulpitis. You can see we have placed a rubber dam, and once the caries is removed, you can see that there's bleeding, quite a significant amount, and this is after removal of part of the radicular pulp. You can see that there is no bleeding and the pulp tissue appears pink. And here we have placed MTA on the exposed pulp surface and restored it with hermetic composite, and the patient is still under observation. It is about 2 to 2.5 years ago which we did this. The patient still has a symptom-free tooth and functional tooth. Follow-up of patients is very critical, because although you do your pulp therapy procedure, it doesn't mean that you can stop and say goodbye to the patient. Please review the patient in about 3 months. Clinical and radiological assessment is necessary. And discoloration is something you have to observe for. Or if the tooth is discoloring, either it can be due to the cements the materials you use, such as gray MTA, or it can be a discoloration due to the tooth becoming non-vital. So therefore, you have to observe and keep close eye on this. And observe every 3 months for the first year, and maybe up to about 5 years, reviews are recommended. The last 2 slides, I will touch about revascularization of the pulp. This is commonly advocated for traumatized immature teeth, because you know, and I'm sure you are well experienced in the fact that immature teeth don't have a good long-term survival because the inferior development of the root. So the objective here is try to revascularize the radicular pulp in an effort to continuing the root formation to a necessary level. So removal of the necrotic coronal and radicular pulp is done, and then you aim to sterilize the pulp chamber through the use of triple antibiotic paste. Once it is sterile, you induce bleeding into the pulp by mechanical irritation of the periapical tissue. And of course, nowadays, it's recommended to use scaffolds and growth factors such as platelet-rich plasma and platelet-rich fibrin to act as a scaffold for the inflowing blood to organize and develop into the pulpal tissue, because you're harvesting or harnessing your undifferentiated cells within the periapital region to induce pulp tissue regeneration as well as root formation. And this facilitates continued root development and apical maturity. And all in all, the advantage here is that you increase the survival of the tooth. So this is an example where the tooth has become non-vital due to caries. Again, we have placed triple antibiotic paste, disinfected, and then placed induced bleeding and placed MT. And you can clearly see after some time, there's promising root development, which is very heartening to note. And also, you know that when the root formation is continuous, the tooth has a better survival. So this triple antibiotic paste was advocated for use in pulp revascularization. I think Varuna will have more insights into this, because he's working constantly on these regenerative aspects and the cellular mechanisms underlying. And with deep carious lesions, they recommend that you go for a very conservative approach. So I think that is all I have lined up here, and I think I will now hand over the presentation to Professor Varuna Dissanayake to give you the state of the art and the newest findings with regards to management of pulpal pathology. Thank you.
Yeah, so thank you, Professor Manil Fonseca, for the introduction, and also thank you, Dr. Danushka Levke-Bandara and Dr. Gishan Edirisinghe for the invitation to share some views and concepts, especially emerging concepts in regenerative endodontics. So it is an honor to share the stage with Professor Arambiwatha and Professor Fonseca. So in the next 30 minutes or so, I will take you on a journey through the evolving field of regenerative endodontics. Yep. So first, we'll explore vital pulp therapy, delving into its underlying rationale. So I'm not going to talk about the procedures themselves, but I would rather focus on the latest advancements and also the ongoing discussion about vital pulp therapy and also what lies ahead for this essential treatment. And next, I'll highlight pulp revascularization or revitalization procedures, discussing their outcomes and growing clinical relevance. So finally, I'll introduce tissue engineering-based strategies for dental pulp regeneration, so offering a glimpse into the future. So regenerative endodontics broadly refers to biological procedures that promote the regeneration of damaged tooth tissues, including the dental pulp and dentin. So this definition clearly states that the aim of these procedures is the replacement of lost cells and root structure without making the claim that this replacement is a complete recapitulation of the once lost tissue. So when we talk about regenerative endodontics, there are three main goals we are aiming for. So first, we want to resolve inflammation and promote healing in the pulp and surrounding periapical tissues. And second, especially when treating immature permanent teeth, we look for continued root development to ensure the tooth matures properly. And third, it is all about preserving or even restoring the vitality and function of the tooth. So when we talk about regenerative endodontics today, so we are really referring to three main approaches: vital pulp therapy, pulp revascularization or revitalization, or also known as regenerative endodontic procedure, REP, and tissue engineering-based strategies, which for now remain mostly in the preclinical stage. So vital pulp therapy is considered a regenerative technique because it aims to support the natural healing and repair of the pulp rather than removing it altogether like in traditional root canal treatments. So the goal here is to set regenerative endodontics apart from conventional approaches. So during the caries progression, the bacterial biofilm moves through the dentin and kick off a whole inflammatory reaction. So I'm not going to go into details. Professor Arambivat already mentioned about the immune reaction that can be triggered by this inflammatory response. So, but if things keep getting worse, the blood vessels in the pulp swell up, causing severe inflammation. So currently, we identify the inflammatory stages as reversible and irreversible. But all these terms, reversible, irreversible, although sound clear, the reality inside the tooth is not so black and white. So there's really no sharp boundary where you can say, now this pulp is past saving. So it's more of a gradual process than the current guidelines suggest. So traditionally, the thinking was, since the pulp chamber doesn't stretch much and doesn't have a lot of backup blood supply, it can't really handle the pressure or bring in enough immune cells to fight off infection. So, but the new evidence shows the pulp is not as defenseless as we once thought. In fact, it can actually adapt to small increases in pressure, and it ramps up a pretty strong immune response when it's under attack. So that's why if you remove the infected crown part of the pulp, this dentin bridge formation can act as a barrier and help save what's left on the healthy pulp tissue. So with this new understanding, we are now seeing a move toward biologically based treatments, like expanding vital pulp therapy, which traditionally aim to treat immature permanent teeth with pulp inflammation. And now we know the pulp can actually heal and defend itself if we can control the inflammation. So if we talk about how our perspective on vital pulp therapy is changing, the big idea behind vital pulp therapy is to keep as much of the pulp alive and functioning as possible by using its natural ability to repair itself. So traditionally, we used vital pulp therapy mostly for immature teeth, as I mentioned, but now the scope is much broader, and there's growing evidence that even teeth showing signs of irreversible pulpitis, like Professor Manil mentioned, can be treated successfully with pulpotomy. So the results are comparable to a well-done root canal in these situations. But the question is how much pulp you need to remove, and also how much you need to save. So this depends on how healthy the tissue looks during treatment. So currently, you need to rely on the amount of bleeding and also how well you can control bleeding, and what the tissues look like under the microscope, if you're using microscopes, or to your naked eye. So just because a patient is diagnosed with irreversible pulpitis before treatment doesn't mean you have to go straight to a full pulpectomy. So if you look at the success rate of pulpotomy, so first of all, when a tooth has normal pulp or just reversible pulpitis, the success rates between partial pulpotomy and full pulpotomy are pretty much the same. That means partial pulpotomy is a great, minimally invasive option in these cases. But what about mature teeth with exposed pulp? So there's no strong evidence that partial pulpotomy is better than full pulpotomy in these cases. In fact, when we are dealing with irreversible pulpitis, full pulpotomy consistently shows better and more predictable results. And meta-analysis have suggested that full pulpotomy success rates can range between 92% to 99%, which is noticeably higher than partial pulpotomies, which is 78 to 80%. So one study even found that full pulpotomy success ranged from 75 to 95, and that includes teeth with clear signs and symptoms of irreversible pulpitis. So, and also we need to remember that younger patients are especially good candidates for vital pulp therapy because their pulps have better blood supply, open root apex, and haven't gone through age-related changes. So I want to mainly focus on some of these ongoing discussions related to vital pulp therapy. So one big topic of discussion right now is how we actually classify pulpitis. So the traditional terms, reversible and irreversible, might be too simplistic, and more experts are saying pulpitis should be seen as a spectrum with stages like mild, initial, mild, moderate, and severe. But it turns out it's not so easy to tell the difference between the very early stages, like initial and mild pulpitis. In practice, these often blend together and seem to respond the same way to treatment. And another factor that's getting attention is caries depth. How far the caries goes into the tooth can help us decide how severe the pulpite really is. So especially when trying to sort out mild from severe cases. So we also know from histology that extremely deep caries usually means worse inflammation, more infection, and even abnormal calcifications in the pulp. So based on all this, some experts are proposing new ways to classify pulpitis. So one such classification could be mild, moderate, and severe. And another is reversible, partially irreversible, and fully irreversible. So, but there's still no consensus on which system is best. And one of the big challenges in endodontics today is also figuring out how healthy or inflamed the pulp really is. To make confident decisions with the upcoming pulpitis classifications, we need simple, affordable, and reliable ways to measure pulp vitality and inflammation. So for example, pulse oximetry is a promising tool, but right now it's not portable or small enough to fit comfortably in parts of the mouth. So we need to see improvements so it works for both front or the anterior or the front posterior teeth. So currently, there's also no truly objective test for how inflamed the pulp is. So most of the time, clinicians have to judge by the color and amount of bleeding when they reach the pulp, which is pretty crude and subjective. So that's why there's ongoing research into using inflammatory mediators as more precise indicators of pulp health. So the aim is to develop point-of-care tests that analyze dentinal fluid in non-pulp exposed cases and pulp blood in pulp exposed cases for markers like MMP9. So these biomarkers could give us a clear scientific readout of tissue destruction. So if we dive into the materials, so Professor Manil mentioned about the recommended materials right now. So calcium hydroxide, although has been the go-to choice for a very long time, it's no longer recommended in many situations due to the drawbacks and also the low success rates long term. And now the spotlight is on the calcium silicate cements. So the clinical results have been impressive. And when materials like MTA are used for VPT, we see success rates of 85 to 100%. And also it's worth noting that calcium hydroxide glass ionomer cements and also resin-based materials don't perform as well, with success rates ranging from 43 to 92%. So as Professor Manil mentioned, there are some downsides to MTA as well, like the risk of tooth discoloration and also the longer setting time and so on. But the resin-based materials, despite that they are easy to handle with good mechanical properties, are not recommended for VPT. And also from our collaboration with the University of Michigan, we have developed a brand new GELMA TCP scaffold as an alternative to traditional pulp capping materials like MTA or biodentine. So what makes this new material so promising is it's ready to use format. There's no need for any special handling skills or waiting for it to set. And we have shown that it is therapeutically effective as MTA. And also going forward, the recent advancements of artificial intelligence and big data analysis lead closer to creating models that can predict the status of a patient's pulp vitality. So this could pave the way for personalized, more precise vital pulp therapies for people with pulpitis. And outgoing research is also digging deeper into what actually happens biologically after pulpotomy and how different tools affect pulp tissue. So these findings are going to help us better understand complications and lead to improvements in the tools and materials in vital pulp therapy. And also we can make these procedures more consistent and effective. And it is also important to recognize that most of what we know so far comes from short-term or single-arm studies. So which means there's a risk of a bias in these results. So that's why the field really needs large multi-center clinical trials to produce stronger, more reliable evidence on pulpotomy outcomes. So even though vital pulp therapy is often described as a regenerative endodontic procedure, what actually happens in the tooth is not full regeneration. The calcific barrier or apparative dentine that forms after the procedure is not identical to the original dentine pulp tissue. So because of that, when the tissue engineering field was developed in from 1990s, they identified there are three major factors that determines the success of tissue regeneration. So stem cells are the building blocks capable of becoming different types of tissue. And then scaffolds or biomaterials act as the framework, giving these cells a place to grow and organize. And signaling molecules or growth factors are like the project managers. They tell the stem cells what to do and when to do it. So all these elements have to work together to get a predictable, successful regeneration. So if we dive into what it really takes to regenerate dental pulp tissue, the first step is getting stem cells to the site of injury. And once they are there, we need to encourage them not just to multiply, but also to turn into odontoblasts. So this is where growth factors come in, either from the dentine itself or added from outside. So these growth factors act like coaches, signaling the stem cells to become the right type of tissue to form new dentine, blood vessels, and nerve growth. So a big leap in endodontics was the introduction of pulp revascularization, also known as revitalization. But due to the confusion of these two terms, now the recommended term is regenerative endodontic procedure, which is the REP. So the process usually takes two steps, as Professor Manil explained. So I'm not going to go into the details of the procedure, but the key factor here is the induction of blood clot, so that this blood clot can act as a scaffold material for the cells to migrate into and differentiate into a pulp-like tissue. Even though inducing a blood clot sounds simple, it's not always easy to do in practice. So, and also blood clots have some drawbacks as scaffolds. They are not the easiest to deliver exactly where you want. And also they lack strong mechanical properties. Their breakdown can be hard to control, and they don't always carry enough growth factors for optimal regeneration. So while blood clots were a breakthrough for regenerative endodontics, there's still a need for better scaffold materials going forward. So instead of relying solely on blood clots, clinicians can also use platelet concentrates. So these are the materials made from the patient's own blood. So these include platelet-rich plasma, platelet-rich fibrin, and concentrated growth factor, or CGF. So these autologous scaffolds are easy to prepare, require little manipulation outside the body, and also can provide a 3D fibrin network, which can be supplemented with bioactive molecules. So many cases using these scaffolds have shown successful outcomes. Still, there are some drawbacks in clinical practice, such as variability and in preparation and also in handling. So another alternative is the use of exogenous or synthetic scaffolds like collagen type 1 hydrogel and collagen hydroxyapatite materials. So these materials are usually loaded with growth factors before being placed into immature root canals. And the clinical results have been promising, equal or exceeding the standard REP outcomes. So overall, the regenerative endodontic procedures or pulp revascularizations show impressive success rates, which ranges from 83 to 100%. And the primary goal is to eliminate symptoms and achieve bony healing around the tooth. So studies show it's achieved in about 91 to 94% of cases. The secondary goal is to increase the thickness and length of the root walls. While this is not absolutely necessary, according to guidelines, it is definitely a desirable effect. So results here vary widely from even some reduction in root length or thickness in a few cases to remarkable gains of up to 70% in others. And the tertiary goal is getting a positive response to pulp vitality testing, which suggests, or which is at least which is expected to suggest the regrowth of more organized functional pulp tissue. So from a clinician's perspective, the ideal REP outcome is clear, which are the radiographic signs of healing and root development, along with the positive sensibility test after treatment. So if we look closely at what's actually happening inside the tooth after pulp revascularization or REP, while clinical outcomes are promising and most case reports show success, histological studies tell a more complex story. So instead of true pulp tissue, the new tissue that forms is often a mix of tissues, which consists of bone, cementum, periodontal ligament, and some pulp-like tissues. So that means a positive pulp sensibility test after REPs is not definitive proof that true pulp regeneration has taken place. It simply tells us that there's vital tissue present, which may include cementum-like or bone-like tissue, along with some nerve fibers. So why do REPs often result in a mix of tissue types inside the root canal? So there are multiple contributing factors, but one of the main reasons is the recruitment of a heterogeneous mix of stem cells or progenitor cells from the apical tissues. So especially stem cells from the apical papilla and periodontal ligament stem cells. So if you recall the development of the tooth, the stem cells from apical papilla come from the dental papilla. So these are naturally inclined to form dentine. And in contrast, periodontal ligament stem cells come from dental follicle. So these are responsible for developing periodontal ligament, cementum, and bone-like tissues. So when both type of cells are recruited during REPs, it's no surprise that the resulting tissue is a mixture of these different structures. So to overcome this, we are, so some of our ongoing research is focusing on nanotechnology to selectively attract subpopulation of stem cells from apical papilla with a superior odontogenic potential into the root canal, leaving the periodontal ligament stem cells out. So the goal is to encourage more organized dentine-like tissue formation. And because of the challenges of regenerating authentic pulp-like tissue in pulp revascularization process, the field is now also exploring advanced strategies like stem cell transplantation and cell homing to achieve true organized dental pulp regeneration. So if we talk about the tooth's own resources in pulp regeneration, during tooth development, growth factors are locked or fossilized inside the dentine matrix. So these proteins don't just sit there forever, so they can actually be released when the dentine is demineralized, either by caries or by certain medicaments used during root canal preparation. So once these dentine-derived growth factors are set free, they are potent enough to attract stem cells to the site and guide them to become odontoblast-like cells. So this understanding has led to an exciting frontier in pulp regeneration, so cell homing. So cell homing is built on the bioactivity of dentine matrix-derived proteins. While this protocol is not yet translated into the clinic, this approach has been considered promising in regenerative endodontic field. So after preparing and disinfecting the root canal, EDTA is used to condition the dentine, and the EDTA solution, now rich in dentine-derived growth factors, is collected and mixed with the scaffold material. And this mixture is then injected back into the root canal. So by tapping into the tooth's own bioactive potential, we can drive pulp regeneration from the inside out. So in contrast to cell homing, another exciting method is stem cell transplantation. It involves isolating stem cells, expanding them in the lab, and then loading them onto a scaffold before transplanting or injecting them into the root canal to jumpstart pulp regeneration. The goal here is to carefully recreate the natural environment of the pulp-dentine complex. So that means we have to consider much more than just the cells themselves. We also need to think about how the cells interact with other cells, with their scaffold, the presence of growth factors and signaling molecules, and even the physical and mechanical properties of the environment. So it's a complex, multidisciplinary challenge, but stem cell transplantation could pave the way for more predictable, organized tissue regeneration in the future. So in several animal models, we have also shown that injecting dental pulp stem cell constructs into root canals can lead to the formation of pulp-like tissue. So there have also been some impressive clinical milestones. In 2017, a Japanese research team successfully regenerated pulp tissue in permanent teeth with irreversible pulpitis using mobilized dental pulp stem cells. And in another clinical trials, they used stem cells from deciduous teeth to treat immature permanent teeth with pulp necrosis. So the regeneration of pulp tissue in these situations or in these studies were complete with blood vessels and sensory nerves. So the translation of this stem cell transplantation therapy to everyday clinical practice is a major challenge. The procedures are complex. There are also hurdles like potential contamination, regulatory barriers, and high costs. So in summary, while stem cell transplantation has demonstrated potential several practical and regulatory challenges, still regulatory challenges that still need to be overcome before it becomes a routine clinical option. So if we zoom out and look at pulp regeneration as a big picture process, successful regeneration depends on a complex interactive response involving blood vessels, stem cells, and immune cells, and all triggered by inflammation in the tissue. So the immune response is especially important. If immune cells can contain or eliminate the infection, often with some help from clinical interventions, then the stage is set for dental tissues to start regenerating. So I would also like to take a quick detour from pulp regeneration to talk about whole tooth regeneration, a topic that's getting a lot of buzz lately. So a Japanese research team recently identified a drug, an antibody that blocks a natural inhibitor of tooth development called USAG1. So this drug, the drug is P26 peptide, can act as a switch that can wake up the dormant tooth buds and restart tooth development. So the animal studies have been conducted and the results are promising. A single dose of this drug has regenerated new functional teeth in mice, ferrets, and dogs. And now they are conducting phase 1 human clinical trials, focusing on patients suffering from the congenital tooth agenesis. So while the hype is real, it will be some time before whole tooth regeneration is a clinical reality, because there are a couple of other things that they need to solve, especially although this drug can influence the number of teeth, it doesn't give us precise control over tooth size, shape, or position in the jaw. So finally, I would like to summarize what I discussed today. So what can we look forward to in clinical regenerative endodontics, maybe in the next 5 to 10 years? So as I mentioned earlier, the evidence base for vital pulp therapy is growing, and more training and extended guidelines will give clinicians the confidence to apply regenerative treatments, not just in immature teeth, but also in mature permanent teeth and in more complex cases. And to support this, we will see new pulpitis classifications along with advanced biomarkers and diagnostic tools. And artificial intelligence will play a big role in helping us use patient-specific diagnostics and biomarkers to pick the best cases and predict regenerative outcomes. So this means personalized protocols based on each patient's pulp status, age, and overall health. We can also expect enhanced irrigation solutions, better antibacterial strategies, and novel pulp capping agents. So clinicians will have more materials to choose from, allowing for case-by-case decision-making. So when it comes to whole pulp regeneration, cell homing strategies are likely to be the first to reach the clinic. They are simpler and more practical than stem cell transplantation because they don't require complex lab procedures. So in short, the future is all about precision, personalization, and practicality in regenerative endodontic procedures. So yeah, I would like to thank you for all of you for attending this webinar. So I would like to take any questions if you may have.
Thank you very much for the presenters and for your elaborative presentations. I think it is open for the audience to ask questions. I believe there's a question shared through the chat by Ms. Mifra Razak. It says, thank you for the informative and detailed session, sir. I have a question that extends a bit into the research side. When working with human dental pulp stem cells in cell culture studies, do you think it's better to start from primary cell culture cells and characterize, or use established cell lines? Also, can we rely on morphological features alone to identify stem cells during culture instead of going for a surface marker analysis? I believe I'll direct this question to Professor Varun.
Yeah. So yeah, I think it's a great question. So so if you would like to culture or work with dental pulp stem cells, so currently there are no cell lines for dental pulp stem cells, because when you say a cell line, it is a immortalized cells, immortalized cell line. But some companies in the US, they offer, or they have commercialized dental pulp stem cell products. So either we can purchase that kind of primary, still they are primary cells. So we can purchase primary cells from a company, or we can isolate the dental pulp stem cells from a donor or from a patient. And but we need to characterize the isolated cells for their stemness before we use them in research or any clinical studies. So regarding your second question, can we rely on morphological features alone to identify stem cells during culture instead going for a surface? So currently, we can't rely on morphological features, because if you look at their morphology, the morphology is more similar to that of fibroblasts, the pulp fibroblasts. So under the microscope, without doing any specific staining, we will not be able to differentiate between dental pulp stem cells or pulp fibroblasts. So we definitely need to do surface marker analysis. So we need to look for the mesenchymal stem cell markers. At least we need to, so these cells need to be positive for 3 or 4 mesenchymal stem cell markers, and should be negative for the hematopoietic stem cells. So that is the current criteria. And also we need to confirm their differentiation capacity to odontogenic, chondrogenic, and neurogenic or angiogenic lineages. Yeah, so I hope I answered your question.
Thank you very much, Professor Varna. If you have any more questions, you can direct them. If you can even ask directly. Yeah, we don't seem to be having much questions. Maybe the presenters were very clear about what they were saying today, I'm pretty sure. And just to ask one question from everybody, um, I think we have received a question. Sure. Okay. I know, not okay. Just to ask a simple question from everybody. Now, from the presentations, what I understood is, despite there are new developments and newer materials, newer classifications coming up, it seems that we still rely on the basic clinical features, clinical symptoms and signs in order to come to a diagnosis. Uh, at what point do you think we'll be able to clearly say, okay, this pulp is irreversibly impaired, but not completely? Is there any possibility that we might be able to make that conclusion? Anybody can answer.
Yeah, so yeah, maybe I can go first.
Yeah.
Yeah. So yes, I mean, so this is the one of the major questions that like endodontists and also pulp biologists debate on. So so the one of the key requirements is to identify the level of inflammation more precisely in order to predict the prognosis of the treatment and also to decide what treatment we need to do for a particular tooth. So currently, what the people working on this aspect are discussing on is that mainly we need to identify some biomarkers or some kind of a chair-side test that we can confidently say what the level of inflammation of the pulp is, or at least whether that test results can give us an answer to decide whether this tooth has a prognosis if we continue with vital pulp, good prognosis if we continue with vital pulp therapy. So there are lots of research going on, lots of clinical trials going on about identifying biomarkers and inflammatory biomarkers as well as other markers. So far, the results have not shown any particular biomarker other than MMP9. But again, MMP9 is not a specific enough marker. So this is the current status. But there will be more precise guidelines in the future because of this expanding knowledge base in relation to vital pulp therapy.
Thank you very much, Professor Varna. Yeah, Professor Mani.
This, I think I have to agree with Varuna as to the flow of different diagnostic criteria and things like that. Because unlike in the past, nowadays there's a lot of research going on to this, and of course, clear protocols have to be developed, and we should, in introducing protocols, changes in diagnostic criteria, etc., we have to be very careful, because once it is put in place and once it comes into guidelines, if there's some error, or if the diagnostic criteria is not clear cut, then it introduces a lot of confusion among the clinicians. So I think we should not rush into creating criteria and then changing criteria all in rapid fashion. Rather, we have to wait till we get definitive and unequivocal results to say that, okay, these are the criteria which determine whether the irreversible pulpitis has affected the entire thickness, or there might be other criteria to say that the entire pulp is involved. So until those proper clear criteria determined, I think we have to stick with the traditional ways. And of course, working with biomarkers and things like that takes a lot of time. And of course, we have to put into clinical practice and then again troubleshoot. I think the best example for that is these COVID vaccines, which were developed in very rapid fashion. And probably if it took its natural course of action, we would have had a better success rate with the vaccine and less side effects. So these are some things we have to consider. Thank you.
Thank you very much, Professor Mani. Right. Seems like we don't have any further questions from the audience. So in the absence of the questions, I would like to conclude this webinar today, thanking all the resource persons for their valuable time given to us and sharing your knowledge and expertise with everybody who have joined here today. And in fact, we reached the maximum capacity very quickly. That shows the keenness the audience has shown in participating in this webinar. And I would like to, on behalf of the College of Dentistry and Stomatology, share or rather hand over the token certificates of appreciation. And since we can't physically give it over Zoom, I will just share the screen and show the certificates one by one. Professor Arambavatta. Professor Mani Fonseca.
Thank you very much, Kishan.
And Professor Varuna.
Thank you. Thank you, Dr. Kishan.
So on behalf of the College of Dentistry and Stomatology, I would like to thank all who participated today as well. And this is another successful webinar that we brought to you to educate and update you on a very interesting and timely topic. And I would like to again thank the resource persons and for their valuable time, and Professor Varna, who joined from Hong Kong, and in fact, in preparation also he joined us for various discussions. So thank you very much, everybody. And in the future, we'll hope to join again with another valuable topic for everybody to update themselves. So thank you very much. Have a great evening and a great weekend.
Thank you very much, Kishan, for coordinating everything, and wish you a pleasant evening. Thank you.
Thank you.
Thank you.